I'm Dr. Carolyn Fronczak, and I'm a urologist at the Boulder Medical Center. I was born in Boulder, and I was born at the old Boulder Community Hospital. And ironically, now I work across the street from that facility. So I do want to thank Boulder Community Health for inviting me to give this lecture tonight. I'm going to be focusing on prostate cancer, and it's a very important focus, as this next slide demonstrates. So prostate cancer in men in the United States is still the #1 cancer that's diagnosed each year. And it is the second leading cause of death. This is not death from something else and the man had prostate cancer. This is actual death from prostate cancer, metastatic prostate cancer. So tonight I want to talk about what are the risk factors for prostate cancer? What puts a man at greater risk for having a meaningful and lethal type of prostate cancer? I want to really dig into the PSA, the prostate-specific antigen blood test. This test has been basically given a bad rap, and we use it much more wisely now, and it's still a very integral part of our being able to help diagnose men for lethal prostate cancer. I also want to talk about the AUA, American Urologic Association guidelines for when to get your PSA checked, and also spend a lot of time on talking about the new, novel, non-invasive diagnostic techniques that we're using to determine whether a man should get a biopsy or not, and also what to do when you have a new prostate cancer diagnosis. First, I want to, though, talk what organ am I talking about? So the prostate is actually a gland. It produces 30% of your semen, and it grows throughout an entire man's life. So that's why a larger prostate is expected in men as they get older. It is below the bladder, and it's in front of the rectum and below the bladder, and our only physical exam finding for this gland is called the digital rectal exam. Digital as in finger rectal exam. So you can see on the right, a rectal exam is being done. I do want to highlight I have a very small finger, so that's one of the benefits of coming to a woman urologist. But this exam, I'm looking for whether the prostate is large or what is its consistency in terms of, is it nodular? That sort of indicates there could be prostate cancer. Is it smooth? Is it symmetrical? And I'm also finding out if the man has a lot of pain when I'm doing this exam. The risk factors for prostate cancer. So obviously being male and older, risk factors. Also ethnicity. African Americans have more likely chance that they're going to get prostate cancer, and also over 2 times likely chance they are going to die of prostate cancer. Also family history. If you have a brother or if you have a father who's had prostate cancer, 2 times more likely that you will have prostate cancer. If you have a brother, you're 4 times more likely. And if you have a brother and a father, you're 8 times more likely. And the prostate cancer diagnosis in such men with a family history, it's not the low-grade type prostate cancer typically. Often it's the more high-risk, lethal type prostate cancer. Also, let's talk about family history of cancer. So if you have a family history of metastatic prostate cancer, ovarian cancer, male or female breast cancer, colorectal, endometrial or pancreatic cancer, higher risk for having prostate cancer. Also, germline mutations, very hot topic now in urology. BRCA2 and the HOXB13 genes that are being found, the genetic mutations, higher risk of finding aggressive prostate cancer in that man, getting diagnosed with prostate cancer earlier than 65. And those men, we should begin screening for prostate cancer at the age of 40. There's also a host of other DNA repair gene mutations that are being looked at that are associated with more aggressive prostate cancer, metastatic prostate cancer. And the importance of knowing these genes is that there's certain new treatments with PARP inhibitors and chemoplatinum-based chemotherapy that can be found to target these men who have these germline mutations. I'm not going to get into metastatic prostate cancer treatment tonight, but I do want to throw out there that if you have anybody with germline mutations in your family that's known, Ashkenazi Jewish ancestry, family history of prostate cancer, or multiple cancers in the family, getting genetic testing is not a bad idea, and I know Rocky Mountain Cancer Center has an excellent genetic testing program. Also, interestingly, one of the medications that has been used for years to help treat enlarged prostate or benign prostatic hyperplasia, called 5-alpha reductase inhibitors, has been associated with an increased risk of prostate cancer. One of the reasons is that this drug actually cuts the PSA value in half artificially. Meaning if that man is on Proscar or Avodart and they get their PSA checked and it's 2.5, it's actually an elevated PSA. You actually have to double that to 5 to be accurate. And there also are clinical trials that show that 5-alpha reductase inhibitors, while they can prevent low-grade prostate cancer, possibly, they have been shown to increase the risk of higher-grade lethal-type prostate cancers. Let's talk about the PSA. The PSA is also called the prostate-specific antigen. It is a blood test. And it is a blood test that was initially approved to be used as a screening tool for prostate cancer in 1994 by the FDA. I have this slide here produced by the Sears cancer data that comes out every year. And I've shown here that in 1994, this is where the arrow is, this is when the PSA came into practice with primary care physicians and urologists. And you can see that when the PSA came into practice, the number of prostate cancers that got diagnosed went significantly up. I mean, there is a large increase in the incidence of prostate cancer being found. It leveled off, but it still was much higher than it was before the PSA came into play. And so with that came some lot of good and then some bad. So the good is that the PSA actually reduced the mortality of prostate cancer by over 50%. But the bad was that the PSA is not just a prostate cancer specific marker. It can be elevated for several reasons, including an enlarged prostate, if a man has an infection like a prostatitis or an epididymitis, if they've done recent ejaculation, have trauma to their pelvis, had a recent Foley catheter placed, or if they've even gone on a recent bike ride and then gotten their PSA checked soon thereafter, that PSA can be higher, and it's not necessarily an indication of prostate cancer. These next couple slides, I'm not going to go through all the details, but these slides are posted online, and if you're interested, you can definitely look. But they basically are quoting some older studies that really looked at the PSA and the importance of it in terms of diagnosing prostate cancer. And to summarize these two sets of slides, just because you have an elevated PSA doesn't mean you have prostate cancer. But just because you have a low PSA doesn't mean you don't have prostate cancer, because some prostate cancers don't make PSA. And there's also new data showing that certain lower levels of PSA below the normal threshold of 4 might indicate that there is prostate cancer in earlier ages. I'm not going to go into that. That's new data coming out. But I'm just trying to say that the PSA, it has to be taken with other information. So the early detection that happened after the PSA came into play led to a lot of prostate cancers being treated that were low risk, low grade, and would never have caused a harm to that man and was not a lethal prostate cancer. It led to a lot of unnecessary side effects and anxiety and increase in healthcare expenditures. So there was a very strong response to this finding of overtreatment. And it basically came in the Preventative Task Force recommendations, which is a very highly respected task force that comes out with recommendations on how to screen for various diseases. So in 2008, basically the Preventative Task Force said, stop doing PSAs. And they gave it a rating of D, do not do, and interestingly, the task force was not made up of a single urologist or an oncologist. It was other specialties of medicine that came up with this guideline. And so what happened? Basically, you'll see with the large oval, yellow oval that I have here, the number of prostate cancer diagnoses started to precipitously fall. So the incidence of prostate cancer went way down, and it went down, quite rapidly over over 8 or so years. And with that, SEER data just published this year is showing that the relative 5-year survival by stage of prostate cancer is actually starting to get less, and that's not good. So before we had survival of all stages between 97 and 100%, and now it's 96 to 98. And the SEER data is always delayed a few years because they take a whole bunch of information that is not just from this year. Although it's published this year, it's not data from this year. So we still are trying to determine what is the effect of not doing PSAs for those few years. The preventative task force, one more slide I want to share is that also we are seeing higher grades of prostate cancer and also more prostate cancer that's metastasized, meaning it's outside of the prostate, it's gone to other organs and other tissues, and we're seeing that more with prostate cancer because there was no PSA done for several years. So between 2003 and 2009, the distant metastases was about 4 to 6%, and now the most recent data shows 6 to 7%. In 2018, for the first time in 2 decades, the number of prostate cancer deaths increased when we had a 20-year low of prostate cancer deaths. So again, the preventative task force looked at this and said, hey, this is not good that we're having more prostate cancer that's not being found. So they revised their recommendations to a C, meaning basically shared decision-making for men, but they still did not recommend a PSA to be done in a man that's 70 or older, and I'm going to address that in just a few minutes. So the shared decision-making, very important. What that means is that when a man comes to my office and I say, would you like to get a PSA? In fact, I had one of those patients today, and we talked about it. He's older, he's in his early 80s, very, very healthy, and I don't anticipate any harm in his health care over the next 10 years. And he elected not to check the PSA. So we had a thorough discussion, we talked about it, and he said no. But that's what shared decision-making is giving really the power to the patient to make decisions based upon the benefits and the risk. So in 2013, the American Urologic Association, my association, revised their guidelines on who should have a PSA. And I'm just going to briefly address those. Between ages 40 and 54, the AUA says don't do a PSA unless that man has risk factors, like we talked about earlier in the lecture. I tend to not do that exactly. I say about 50, all men should have at least a baseline PSA, and especially if they have a family history of prostate cancer, they should have one between 40 and 45. Ages 55 through 69, definitely I recommend a PSA, so does the AUA. This is the age group with the greatest benefit of screening for prostate cancer and having a PSA be evaluated. Then age 70 and above, the AUA agrees with the task force and they say no PSAs above age 70. They recommend against it. I live in a town that 70-year-olds are still biking and hiking miles a day, and they have definitely greater than 10 to 15 years of quality life, and I encourage those men to get their PSA checked. And I don't follow the guidelines in that sense. Again, it's a shared decision-making, but it is not a good thing when a man gets metastatic prostate cancer and gets a fracture in his hip, and that fracture is due to cancer that's infiltrated the bone. So we don't like that. We want to keep them healthy. So individualized decision-making, shared decision-making, we've come a long way. And basically, we want to maximize the detection of lethal prostate cancers. Not find those low-grade prostate cancers, but find the ones that's going to harm a man in 10 to 15 years. I want to also accurately characterize the biology of the tumor, and I want to risk stratify that cancer. We have these genetic tests now and biomarkers that are helping us tremendously, and I'll go through all of those in just a few slides. So what should you expect for an initial evaluation? Well, it's not going to be doing all the brand new testing, because really the PSA and the digital rectal exam are the key and standard to determine what's next. So we do that initially, and if either one of those, if the PSA is elevated or the rectal exam is abnormal, I'm going to encourage us to do some further evaluation. These slides, the next slide or two, are just basically trying to tell you that a PSA and a DRE should be done. And it's because neither one is going to completely diagnose prostate cancer sometimes, and we have to put the two pieces of information together to move on to other risk stratification. So let me talk about the new non-invasive pre-diagnostic tests that are done to determine whether a man needs a biopsy. And I'm very big on doing these, and so is my partner at Boulder Medical Center, Stephen Siegel. We know men don't come to us saying, hey, I want to get a biopsy, my PSA is elevated. They want to do everything they can to try to prove that they don't need a biopsy. But they're smart and they realize that they may need one, but we need to prove that. I feel we need to have better information. So while a prostate biopsy by insurance companies is still considered the gold standard, it is certainly not mainstream anymore. The downside to the tests are none of them are perfect, and we understand that. And also there's an out-of-patient expense to these tests. Most of the tests are between $200 to $400. If you need to get an MRI and it's not covered by insurance, that's around $700. So the discussion has to be made on cost for the patient. Is that something that they want to do? And most of the patients do want to do that. And if they want to think about it, they usually come back and say, I think I'm willing to pay the expense to find out more about this abnormal rectal exam or this elevated PSA. Again, the goal is not just to find prostate cancer, it's to find meaningful prostate cancer. So I'm going to go through the 6 tests that I've listed below, starting at the parametric, multi-parametric MRI, and then talking about several other liquid tests. So prostate MRI, I use it all the time. It is a wonderful addition to our ability to basically help diagnose prostate cancer. We can't exactly diagnose the type of prostate cancer, but it can certainly give us an idea if a man's prostate should be biopsied. And we use multi-parametric MRIs, and what that basically means is I'm not only getting an anatomical picture of the prostate, a window through the prostate, if you say, but I'm getting all this other information that the radiologist then can use to mark out abnormal tissue or lesions that are considered possibly high-grade prostate cancer. So those additional information are diffusion weighted, and they're also dynamic contrast. An MRI needs to be done with and without gadolinium, and gadolinium is not iodine. It is a different type of contrast. And I use prostate MRI all the time. I love it. It helps me determine who needs a biopsy. It helps me characterize if I felt an abnormal nodule on a man's prostate, is that a benign hyperplastic nodule or is that cancer? It also helps me evaluate a man's prostate if he had a benign biopsy in the past. Did we miss something on that biopsy? And I can get another impression of the prostate with the MRI. Also, I use it for active surveillance for men that have low-grade prostate cancer, and we're just watching it, and we're seeing if those lesions change over time, and we're rebiopsying those lesions in about 18 months to 2 years to see if there's more aggressive tumor. And also, I'm going to talk about what we do with the MRI in terms of biopsy. We do a fusion-guided biopsy, and we will do those in my office about once a month. So when you get an MRI, the radiologist will read it, and they will grade the tissue, and if they see a lesion, they're going to give the lesion a score. And that score is going to be from a 1 to a 5. The scores 4 and 5s are the ones that we really do need to focus on and encourage the patient to biopsy with the new fusion technology. The 1s, the 2s, and the 3s, the 3 is equivocal. It's confusing sometimes, and it's not quite certain, but we have a lot of other options to kind of determine what we do next. 1s and 2s are usually benign prostate tissue, just regular and large adenoma. So here's the information we'll get when we do a fusion biopsy. And let me explain a fusion biopsy. So once a month, we have a company come to my office, and it has lots of equipment, lots of computers, and those computers allow us to basically superimpose or lay down a live ultrasound image on top of the MRI that's been already previously marked out, the lesion's been marked out by the radiologist. So on this slide here, the top left-hand corner is actually the ultrasound, and this lower left is the MRI. Here's the lesion of interest that's been marked out by green. As you can see on the MRI, it's dark, but on the ultrasound, it really doesn't look any different than the other remaining tissue, and that's why you cannot use ultrasound often to find lesions and cancer on the prostate. That's why we've had to go to MRI and the multi-parametric technique. So what I do is I'll lay down these two images on top of each other, and it will come up with this image on the right, and these are the biopsies that have been done in the lesion. Now, I do many, many other biopsies in that lesion. This is just two, and this is not my biopsy. And then we also do our gold standard 12 core biopsies on both the right and the left lobes of the prostate, and you can see those right here in terms of the regular types of biopsies. We still do the 12 core along with just biopsying the lesion, because often we find cancer also in these other gold standard biopsies, the 12 core that we do. And so for staging purposes, you gotta biopsy the standard way plus with the fusion. So the benefits, I have a couple studies here that are well known that talk about the benefits of MRI. But what I wanna really point out here is it's not perfect. So MRI can miss about 6.7% of cancers. And in probably one of the best trials done to determine the benefit of MRI before biopsy, they feel that it could miss about 24% of cancers. This is just MRI alone. But let me just reassure you, just because we get an MRI and it doesn't have any lesions and it's been missed on the MRI doesn't show it, it doesn't mean that we're just gonna call that good. We're gonna keep looking, and we're gonna keep evaluating the PSA, keep evaluating the rectal exam, and do some of these other liquid tests that I'm gonna talk about next to help determine whether we need to do other biopsies or other testing. Also, inter-observer variability, that's another big issue with MRIs. What that means is one radiologist reads the MRI and the lesion one way, and another one reads it another way. One may find a lesion, one may not. The beauty of where I get most of my MRIs done, which is at Boulder Community Health, is that the radiologists that read the MRIs are simply outstanding. And there's two that read each of the MRIs. So it really reduces that inter-observer variability. And I can just tell you from my experience, Boulder Community, I really try to get all my MRIs read by those radiologists there. So now I'm gonna go on to the other kinds of tests that can be done to determine if a man needs a biopsy, and also a lot of these tests help determine whether a man needs further testing after the biopsy. And these are called genomic tests. What is a genomic test? It's a biomarker, basically. It's a substance or a process that shows that there might be the presence of cancer. They're either secreted by the tumor or they're a body's response to a tumor. Again, genomic tests are not perfect, and some will miss cancers, but they give us still a really good idea on what we should do next. So genomic testing is becoming, I took this slide from a recent lecture that I listened to through the AUA, but genomic testing is really becoming a part of decision-making process, all the way from, should I have a biopsy, to what do I do? Like if I have prostate cancer, I get my prostate taken out, it's a high-grade prostate, what do I do next? Do I do further treatment? So as you can see, there's all these genomic tests, and I'll talk about several of them, that are available through each stage of the decision-making process. And the beauty of these is they've really helped us decrease our unnecessary biopsies, but also helped us find where men are having lethal types of prostate cancer, finding where men have lethal prostate cancer. So I'm just gonna go through several of them. Prostate Health Index is a test that has been around for several years, and it is a very good test. I don't use it that much anymore because the area under the curve is not as high, and I know I'm talking statistics here, and I don't want to get into what that means, but basically when you look at some of the tests of these genomic, when you look at how good are these genomic tests, everyone wants to know what is the area under the curve, and again, I'm not going to go into that, but the closer it is to 1, the better the test. So the area under the curve with Prostate Health Index is 0.72. There's newer tests out there that are better, but it's still a well-respected test. And if your urologist said, hey, let's do a Prostate Health Index test, I would certainly welcome him doing that or her doing that. PCA3, one of the first tests out there, I was using it back in residency, and it was finding prostate cancer. It was like one of the first biomarkers that we did. It's a urine test, and it was a good test at the time, but what it doesn't do is help us determine the likelihood that this prostate may have lethal prostate cancer or a high-grade prostate cancer. And so because it can't really do that, it's fallen out of fashion. This would not be a test I would necessarily recommend because of that. 4K score, excellent test. It's a blood test. It takes into account several markers that they say are really associated with finding more high-risk prostate cancer, but it also takes into characteristics of the patient, such as their family history, their age, their rectal exam, and it gives a very nice result, and it also helps tell us if there's meaningful prostate cancer, possibly. What is the likelihood? SelectMDx, one of my favorite tests. I do this test a lot. It's also a urine test that's looking at RNA. And how I do it is you have to firmly massage the prostate. It's a, quote, massage, where it's really, I just press quite hard on the prostate and push some prostate secretions into the urethra. And then my patient urinates soon thereafter and collects some of that prostate secretion in their urine. It gets sent to a company, and they tell us what is the likelihood that there's prostate cancer if you do a biopsy, and also what is the likelihood that there would be meaningful prostate cancer or a grade 2 or Gleason score 7 or greater. I like SelectMDx because it has close to a 0.9 area under the curve when I take into account several other factors of the patient, and it does really give us a good idea on whether this man needs a biopsy or not. EndoDX is actually a new test similar to SelectMDx, but it doesn't require a prostate massage. So this kit can actually be sent to a patient's house. They can do and follow the directions, urinate, and it gives back very accurate results and doesn't require a rectal exam. So that's just another new test. ConfirmDX, now that is a test that there's not any other ones like this on the market that I'm aware of. It's a test that if a man has a benign biopsy, those benign biopsies can be sent to ConfirmDX, and they do hypermethylation on the specimens, and doing that, they can determine if there's maybe more high-risk characteristics to the tumor, and it helps me say to my patient, if it comes back with some methylation, it will tell you exactly where in the biopsy it came back. So if it comes back at the apex or the base, it tells me where. I can correlate that if I get an MRI. I can also say, I think instead of my regular follow-up of let's do another PSA in 6 months or 8 months or a year, I'll have a little more aggressive follow-up with that patient if there's hypermethylation that's found. So I do like ConfirmDX for that reason. And that's again for biopsies that are benign. So if you had a benign biopsy, you can see if you can get your samples sent to Confirm. And then let's talk about what do you do with a new prostate cancer diagnosis. So do you treat it? Do you do a Da Vinci prostatectomy? Do you do radiation? Do you go on active surveillance? And what I mean by active surveillance is, you know you have cancer, you're just gonna watch it. And watching it means you're gonna get a repeat biopsy at some point, possibly 18 months to 2 years. You're going to get an MRI. Maybe there's other genomic tests that we're going to do to determine, how aggressive is this testing. And so what I like to do is do more genomic tests. Sometimes it is very obvious. I mean, this man needs his prostate out or needs radiation. And there's not a lot of benefit in doing a genomic test because it's not going to change our decision making. But a lot of times, the biopsies come back as an intermediate risk prostate cancer. We are finding that some intermediate risk prostate cancers can be watched now rather than treated, and so I want more information on what to do. Before all the genomic tests came out, there was just really risk stratification, and it really tried to be very good, but it's still not as good as doing some of the genomic testing out there that I'll talk about in just a few minutes. When I say prostate cancer risk stratification, there's several different ones that are available. There's the AUA risk stratification, there's the National Comprehensive Guideline, National Comprehensive Cancer Network stratifications. There's Memorial Sloan Kettering. There's several out there that we used to use to help determine whether this man should have treatment or not. And basically, we would focus our attention treating men that had an intermediate risk here or higher. And all of those risk stratifications are based upon PSA, the Gleason score, which is basically what your prostate cancer is given in terms of its grade when the pathologist looks at the tumor, and also the clinical stage. That's really all these cancer stratifications take into account. And we found that genomics adds much more information because each tumor is unique. Some tumors are upstaged and downgraded when they're analyzed with genomics, and it's important to understand that. And we also are finding that understanding just survival from prostate cancer is not necessarily the best approach we want to take when determining if a test or a treatment is successful. And the reason is because prostate cancer, when a man is diagnosed, they can live for many, many years with prostate cancer and have no harm, no effects of that prostate cancer. And even when they're diagnosed with metastatic prostate cancer, which is prostate cancer that's spread to bones or other tissues of the body, they can live for many, many years before that prostate cancer would cause death. So overall survival, they're finding, is not the best way to look at how successful a treatment it is, but instead, metastasis-free survival is. And so that is being found as the strongest surrogate for overall survival in localized prostate cancer. And this lecture is on localized. Localized is prostate cancer that's not metastasized, it's not escaped outside of the prostate capsule. Decipher. Decipher is a genomic test that is one of the best out there, and I use Decipher a lot, so does my partner, Steven Siegel. Rocky Mountain Cancer Center, the radiation oncologists use it. It is just a really good test to analyze tumor because it really does tell us where in the spectrum of risk is this patient's tumor. It was developed at Mayo Clinic. It uses RNA, 22 genes across 7 cancer pathways, and it divides results into high, intermediate, and low risk. And it outperforms all other types of risk stratifications that just take into account a biopsy's Gleason score, a PSA, and the clinical stage. I'm going to give a few examples of how Decipher works. So here is a patient that has these following clinical and pathologic details. So they are a stage T1C, which is a low stage, because that means that the urologist, when they did their rectal exam, felt no nodule, but yet prostate cancer was still diagnosed. So that's a T1C in terms of the pathology. In terms of the clinical stage. This patient has a PSA of 4.9, and their Gleason score was 3 plus 4. This puts them at a risk category of intermediate. So they have an intermediate risk prostate cancer based upon these findings here. So their tumor was sent to Decipher, and it was found to be low risk. So this patient could actually just watch their prostate cancer, go on active surveillance, could feel comfortable about doing that based upon this information from Decipher. And before Decipher, we would have really encouraged intermediate risk prostate cancers on a patient that has 10 to 15 years of quality life to actually treat that prostate cancer, not just go on active surveillance. So Decipher is helping us determine whether active surveillance is appropriate for what once used to be cancer that should be treated with a prostatectomy or radiation. So here's another report, same clinical and pathologic findings. Again, T1C, PSA 4.9, Gleason score 3 plus 4. But this patient has an intermediate risk score from Decipher. So there's a conversation that needs to be done on how comfortable is this patient doing active surveillance, or do they want to go ahead with treatment. Here's a third example. And as you can imagine and guess, this is the same clinical and pathology details, but this patient's tumor came back more high risk, showing that there's a higher risk of metastasis at 5 and 10 years. This patient should highly consider having treatment for his prostate cancer. And Decipher is also helping oncologists and urologists decide what to do with also when the prostate is treated, how do we do additional treatment with androgen deprivation if the patient is having radiation? How long should we do androgen deprivation, or do they need prolonged radiation treatments? What is the next steps for their treatment of their cancer based upon their risk of their pathology? There's other post-biopsy genomic tests, the Oncotype DX, I've used it many times, and Prolaris. I just feel more comfortable with Decipher. I think it is really leading the way in terms of the metastasis-free survival aspect. But if someone had an Oncotype or Prolaris, certainly that's going to give some good information on the patient to the gentleman in terms of deciding what to do. ProMark is another genomic test. It's also very good, but it's only for low-grade tumors. I don't use it because Decipher also does low-grade tumors, so I just tend to be more comfortable with Decipher and reading their reports, so I do Decipher. But these are other options that your urologist may be also using, which I'd feel comfortable with as well. So I'm just going to briefly mention surgery for prostate cancer, being a surgeon. My partner, Steven Siegel, does the prostatectomies for my group. He's done hundreds and hundreds of them. He's excellent, and he does all of his surgeries at Boulder Community Hospital. He uses the Vinci. Vinci has really changed prostatectomies outcomes in terms of basically, getting out of the hospital sooner, and also just having much clearer vision for dissecting nerves off of the prostate. It's really the way most urologists are doing the removal of prostates now, and I would highly encourage this over an open prostatectomy any day. There's very few also urologists that are doing open prostatectomies, so Da Vinci is really the standard out there right now. Basically, I'm done with this lecture at this time. My take-home messages for the audience tonight: take control of your health care. Please get your PSA checked. And if your primary care doctor doesn't feel comfortable doing a rectal exam, ask them to do it, or come to a urologist. Come to me, I'll do your rectal exam. It is so important, because we can't ignore a cancer that is basically the second leading cause of death of men in the United States. And also, there's just so many other tests that we can do to help you feel comfortable with the decisions that are being made. They're out there, they're available, and please request those tests to be done. And this is just me and my sister at our Ironman earlier this year, which I'm so proud of us.
Thank you. That was very informative. I'm just going to dive right into some of the questions, and we'll get going from that. For this person, their husband is 66 years old with a consistently rising PSA rate, now at 3.8. His GP has not ordered further investigation, which is concerning. What is your opinion on that?
I would like to know what is the velocity change in the PSA over the time. I'd like to know, how fast has it risen? If it's gone from a one, I don't know the numbers, but let me give you some examples. So if your husband's PSA was 2.2, and then went up to 3, I'm sorry, did you say what the value was?
3.8.
3.8. So my first next step would be, let's recheck the PSA with 5 days of pelvic rest. And what I mean by pelvic rest is no sex, no masturbation, no ejaculation, no bike riding. And let's see if what that PSA is when you have pelvic rest. I would definitely do a recheck of the PSA first before I'd get too nervous about that. But you're very correct to look at the velocity. So if it keeps climbing up, we definitely would recommend get referred to a urologist, and we can do some of those additional genomic tests, even do an MRI. Make sure that the practitioners that he's seen has done a rectal exam to offer other options to see what's going on. It's definitely, you got to watch the velocity of the PSA, and you also got to make sure that you have it at possibly the lowest value that it could be, and to avoid any of those activities that may raise the PSA.
Thank you. Do you have any opinions on the 2 new treatments for BPH?
Which treatments?
Like pulling it aside and occluding prostate artery?
Oh, what was the first one?
New treatments for BPH, pulling it aside, occluding prostate artery?
Well, okay, so prostate artery embolization is an option. It is not recommended by the AUA guidelines yet. It's more still considered experimental. I'm just going to tell you, I have a couple patients who've done the prostate artery embolization, and the results have not been as consistent as they should have been. One patient had the wrong artery embolized and has dealt with that for quite some time. I can't give a lot more information than that, but that was not a pleasant experience for the patient. And again, it's not recommended by our guidelines because I think the results are very inconsistent. And so I have very consistent options for your husband that are minimally invasive, that work. I do a lot of UroLift. In fact, Boulder Medical Center is a center of excellence for UroLift. UroLift is one of the newest, about 7 years, it's been around for 7 years, but it's one of the great ways to treat enlarged prostate because I can do it in my office. So I basically take a man with enlarged prostate and they walk out with a prostate where I pulled apart the prostate lobes. And I do that with them awake, with a numbing of the prostate and giving lidocaine in the bladder. They tolerate it very, very well. And so far I've had really good success with the UroLift. We also do Resume in our office. It is a vapor treatment for the prostate. It is using steam to basically ablate those lobes that are obstructing the prostate channel. That's another one we do in our office. So those treatments, the UroLift and Resume, those are highly respected, highly recommended by the American Urologic Association. And I can tell you with confidence the success that I have with those treatments. I certainly cannot vouch for the prostate artery embolization just because I've seen the complications. And so there may be a lot of patients out there that really are doing well with it, and I don't see, but the ones that I see have had some issues, so I wouldn't necessarily recommend PAE.
Good to know. What are the risks of the PSA test?
Risk is, it's a blood test. The risk is basically not there. If you get your PSA checked and it's elevated, your primary care doctor should send you to a urologist. And then we can put together the better picture. We do a rectal exam. We will see if you need to have your PSA rechecked. If you have an infection or any sign of inflammation, or like we talked about recent biking, I'm going to have you recheck your PSA again. So the risk of the PSA is very low. The information that we can gain from it with using it very wisely is very high. So the benefit of it way outweighs any of the risk of the PSA, in my opinion, but that's because I use it wisely and I have access to many other tests, as we've talked about here, to help determine what to do next.
If you're going to have a PSA test, how long before the test, should you stop riding your bike?
I recommend 3 to 5 days. I usually say 5 days, but it's all over the place. Some guys say, some urologists say 3, some say 5. I just say 5, just because then I know for sure that they've definitely done at least 3, and let's go for 5 days.
Okay. Should an annual exam include a digital exam in men 65 to 70?
Absolutely, it should, because I have found multiple prostate cancers where the PSA is normal, but the exam is abnormal. So the DRE, the digital rectal exam, is our only physical exam finding for the prostate. And so it should be included in a yearly exam. And it's often not. A lot of practitioners do not do a rectal exam anymore. And that's also because, I don't know, I actually don't know why, but it's very important to do it. I feel that information is really, again, it puts together the picture, and more information is better. I mean, what you don't look for, you're not going to find. And so I want to look and I want to find, and if I find something, then I want to talk about it with the patient.
Okay. For this person, they're asking, they go to the bathroom 2 to 3 trips in the middle of the night. That's an indication of what?
So that's called nocturia, and that can be an indication of a few things. It can be an indication of an enlarged prostate. It can be an indication of overactive bladder, or it can be an indication of prostate cancer even. So when you come to my office, every patient that's listening to this lecture tonight knows this. They're going to give a urine sample, and they're going to get their post-void residual checked. And so if this man that's asking, or whoever's asking this question says to me, I urinate, 3 times at night, and they get their bladder scan done in my office, which is just a little ultrasound machine right above the pubic bone after they urinate, and they've got 70 or 80 or 100 milliliters of urine still left in there, but they say, hey, I can't empty anymore. Well, then that getting up a lot at night may indicate that that patient has enlarged prostate. And we can do some of our really awesome treatments like UroLift to help open up that prostate channel, and they'll stop peeing so much at night. But if they come to my office and they say, yeah, I get up 3 times at night, but they empty their bladder down to 0, and they say, yeah, and during the day I'm also going frequently, and sometimes it's urgent and I can't make it to the bathroom on time and I have a little bit of leakage, that can mean overactive bladder. That can also mean enlarged prostate. So that's my job to try to decipher what we need to do for you. But it certainly needs to be evaluated. You don't need to accept getting up, more than once a night. Over 80 years old, they say 2 times a night is normal. But I can certainly tell you, I would hate to get up 3 times at night, and I hate getting up 2 times at night, and I don't have a prostate. So I'll tell you, we can work that up and figure out how to make that better.
Okay. What is your view of over-the-counter prostate health supplements?
So that's an excellent question. Saw palmetto, one of the most commonly taken prostate over-the-counter supplements. Not going to hurt you, but they have done study after study after study, clinical trial using high-quality saw palmetto, and it has never shown to be more significant than just placebo. But I have patients that swear by it, and so that's fine. It's not going to hurt you. Super beta prostate, all these other ones on the TV that I hear about or read about, they're not going to hurt you. You can take them, but they're also not going to help. In fact, a lot of drug therapy for enlarged prostate, it's not going to necessarily help all that way. And I'm going to just tell you, Flomax and finasteride, I'm just going to address those 2 drugs real quick. So Flomax, tamsulosin, one of the most common drugs for enlarged prostate. It's not an over-the-counter drug, so I'm kind of digressing from the patient's question. But there's a lot of data out there that's showing that while Flomax may subjectively make the patient feel that they're emptying better, there's still some remodeling of the bladder muscle that's going on that's not going to get better on Flomax. And over time, that man's bladder can basically decompensate even when they're on Flomax. So they can fail Flomax. And by that time, their bladder may actually be worn out or burnt out. And they may not be able to recover their ability to actually start to void to satisfaction and not have bothersome lower urinary tract symptoms. So medical management, whether it's prescription or even over the counter, is honestly not as good and healthy for the bladder as is doing a procedure like doing UroLift or even doing the gold standard transurethral resection of the prostate. Men that come to me with really bad urinary symptoms, bad lower urinary tract, frequency, urgency, getting up a lot at night, feeling like they don't void it all out, feeling like they have to strain to urinate. It's best to get evaluated in terms of like bladder health for that, because once the bladder muscle goes away, it never comes back.
Will you remind us, would you recommend genetic or genomic testing for a 61-year-old with a brother that died of MCRPC?
What was that? Died of which kind of cancer? Metastatic prostate cancer, is that what he's trying to say?
MCRPC.
Okay, metastatic castrate-resistant prostate cancer. So yes, 100% I would recommend genetic testing for you because you have a family member that's died of metastatic prostate cancer. Definitely I would.
Okay. Is there an upside of including a urologist in the team of periodic preventive health visits, or is the PCP sufficient?
I think PCPs play an excellent role in terms of the initial evaluation for prostate health, male health. I don't think you need to necessarily come see a urologist as part of your routine care, although I have many patients that come to see me and don't necessarily need a urologist. They just want a urologist to fill the prostate because I do that all day long. And they know I have a small finger and I'm able to really get around everything in the posterior aspect. So I have a lot of patients. I think it's your choice. Again, I bet it's somewhat insurance driven, but primary care doctors are very good at referring to me when they feel there's an elevated PSA or an abnormal rectal exam, or the patient's having lots of voiding symptoms. Primary care doctors are important, and I think I would trust your primary care doctor, and I would ask him or her whether they think you need a urologist or not.
If a case of benign prostate enlargement is treated with surgery, does this decrease the risk of prostate cancer after surgery?
It does not decrease the risk of prostate cancer. If you do some of the minimally invasive treatments that we do in our office, we don't actually take any tissue out to decrease any size of the prostate, really any significant amount. If you do a gold standard transurethral resection of the prostate, that sometimes, on a rare occasion, I will remove prostate tissue for that surgery and there will be cancer in it that was not expected to be found, because cancer doesn't typically grow where the urethral channel is. It usually grows more on the outer aspect of the prostate. But occasionally, like I said, very rarely there is prostate cancer seen. But no, it doesn't increase or decrease the risk of prostate cancer.
How frequently should PSA be checked?
That's a good question. So there's a debate about that. Yearly or every couple years typically is the answer for that. I tend to go yearly. I just think I can keep track of that better, and I like to see my patients yearly. I like to do their rectal exam. I like to make sure nothing is changed, no blood in the urine, other aspects. So I tend to always do a DRE and a PSA every year. But there is some talk that you don't need to do it every year, and I know in the guidelines it says often you don't need to do it, but every couple years in the earlier ages. But again, it's a decision making between me and the patient. If that patient says, hey, I think I'd like to go every 2 years, I'd be more than happy to do that.
Does diet have impact on incidence of prostate cancer?
It doesn't. There's not clear-cut evidence for that, but I do know that if you have a diet that is really high in fat and high inflammatory type foods, there's always an increased risk for all kinds of cancers with those kind of diets. A low diet, a low fat, high fiber, Mediterranean type diet is still, in my opinion, and this is my opinion, is still one of the best diets to follow, because it's full of a lot of anti-inflammatory foods, and those are the foods that don't encourage, mutations and cancers to form. And again, there's no clear-cut diet for prostate cancer. There's books and books about it out there in terms of this is the diet you should have for prostate cancer. But again, there's not one accepted type food or diet to follow. I think just an overall, healthy diet is what we all need to aim for.
This may relate a little bit to the prior question, a couple questions ago. Do any of the treatments for BPA, steam blood vessel blocking, reduce cancer risk by removing tissue?
No, it doesn't. So when you do enlarged prostate cancer surgery, it's removing adenoma that is central adenoma. It's from the central zone and the median lobe area. those areas don't tend to have the prostate cancer. So the prostate has several different zones. And the peripheral zone, which is the outside, is where prostate cancer is mainly found. And so prostate cancer treatments for enlarged prostate don't reduce that risk, again, because we're not taking out tissue where cancer usually is found.
This is fairly specific here, but do you have an opinion on focal treatments like laser on HIFU for 3+3 or 3+4 cancer?
Good question. So HIFU and laser, I knew I would get asked this question, and so I looked it up before I came a few days ago to see what's new and what is the new data out there and what's some new information. And the overall conclusion is it is available for treatment of localized prostate cancer. Should be done in a clinical trial setting, should be done at a high volume center like Anschutz or UCSF, because they know what they're doing in terms of how to do this treatment. When these treatments are done, there can be a lot of complications. And you got to go somewhere where this is one of their focuses. The reason why it's not yet accepted in terms of our guidelines as a treatment for prostate cancer, and it is not mainstream, it's not to be used as one of the options we offer, is because just because you see a focal lesion, say on an MRI, does not mean that's the only area of cancer in your prostate. So when I do a fusion biopsy, for example, and I biopsy that lesion that I saw on the MRI, I'm also going to do the gold standard biopsy on the prostate. And I'll tell you, a lot of times I see the same kind of high-grade cancer in other areas of the prostate. So it's hard to advocate a treatment where it's going to just focally treat a lesion that we saw on imaging when I know the other side of the prostate may have just as bad a cancer. So we're treating one small area and not treating the other area. The side effects then of trying to go back and do additional treatments on that prostate that's got the cancer can be high, with fistulas and other problems that come along when you do a laser in that area. That's why it's just not yet accepted. There's more research that needs to be done. I would love it if we could just focally treat prostate cancer. That would be wonderful, not to have to take a prostate out, not to have to do a whole gland radiation. But it's just not there yet. And I think there's a huge risk if you don't know you've got prostate on the other side and you're not treating that, then why are we just doing one little focal area? I don't think it's quite there yet. But again, I think you talk to urologists who are educated in it and get their opinion, not get my opinion and not hold to my opinion, because I don't do that. And I'm only quoting you some of the information that I've read in the last few days about it. So please look elsewhere besides my lecture on that information.
Okay. We have several more questions, but we're out of time, so we're going to do one more question here and then close it out, and then people can send you questions after the lecture here. The last question is, can you describe the robotic prostate surgery procedure?
You know, I don't do robotic prostates anymore. My partner, Steven Siegel, does. But it is a great option for treating prostates. It's done laparoscopically. It is where a robot comes in and basically has arms that will be doing all the dissection, but the urologist is sitting at a console that's away from the body, controlling all of those robotic arms. It is 3D vision, so you can really see the nerves, you can see the blood supply, you can do excellent dissection with it. You have really all these degrees of motion with the wrists, and it's excellent for prostates because prostates sit in a very narrow pelvis of a man. And getting all your hands down in there, it's a small area, whereas the robotic arms can go right down in there and dissect everything off with 3D vision. That's about what I'd like to say about robotic prostatectomy. But they have the robot, a really nice robot at Boulder Community Hospital. And it's definitely, if you're thinking of getting your prostate out, that's the way to go.